Welcome to Fluorescene.
Hi, I'm Dr. Andrew Steele with Bennett & Bloom Eye Centers in Louisville, Kentucky. I also serve as co-curator of Retina Rocks, the world's largest online retina image bank. I also have the privilege of practicing with its founder, Dr. Steve Bloom. I wanted to share a case with you today that we shared on Retina Rocks Instagram page a few months ago, but I had the opportunity of managing this case from beginning to end, so hopefully I can offer some insight for you. So let's get started. A 46-year-old, otherwise healthy Caucasian female presented to my clinic as a referral from the emergency room for unimproving conjunctivitis. 2 weeks prior, she noted that her vision in each eye, but far worse in the right, was getting fuzzier, and she was having an increase in pain and light sensitivity. When she presented to our clinic, her vision had dropped in the right to about count fingers and best corrected in the left eye to 20/70. There was an obvious inferior defect in her right eye, and there was some irregularities in pupil response. But on a slit lamp exam, I could see a dramatic anterior chamber reaction, asymmetric, far worse in the right eye in the left, but it was granulomatous. There were granulomatous mutton fat KPs on the endothelium, and I could see a bit of vitritis in the right as well. So a number of differentials already are starting to come to mind. So we dilate this patient, and though the view is hazy, we can see on this first photo, and this is on the 1st of September. This first photo, you can see through this hazy media a large patchy area that's whitish and yellowish that extends to the far superior temporal quadrant with these focal areas that are bright, representing some retinitis or retinal precipitates. So we certainly initiated some topical steroids in each eye, along with cycloplegics, but discussed with her, most importantly, the need for stat blood work. So I gave her a list of blood work, which included ESR, CRP, CBC with diff. Quantiferon gold is also critical in these cases. We're looking at angiotensin-converting enzyme, serum lysozymes, FDA-ABS, RPR, and a few others. And so I was able to talk with the laboratory in the hospital where she had actually come from the ER, and told them about this case and the scenario, and was able to expedite this blood work, and she was able to get it done that day. So I invited her back 2 days later when I already had her blood work. This is on the 3rd now of September, and it was remarkable. The ESR was elevated, and also she had a reactive FDA-ABS and a reactive RPR. So in this clinical setting, of course, this is convincing for syphilis, and in this case, a syphilitic panuveitis with retinitis, and a bit of papillitis is seen. And so of course, we did not wait any time to initiate treatment, and a standard of care as well, given these retinal findings, is appropriate whether we treat this as neurosyphilis. So I ordered an HIV screening, as it is often comorbid with some of these conditions, and also ordered a lumbar puncture with CSF analysis. Now that was going to be a bit of a delay, but given the need to manage and monitor her ocular findings, I had opted for daily intramuscular injections of procaine penicillin, along with adjunctive probenecid. Now, probenecid is an oral pill that I had her take 2 grams daily. That's 500 milligrams QID. And it's a drug that is used in chronic gout. and it affects the excretion. Actually, it lowers the excretion of the penicillin, increasing its efficacy. Now, this is one of the options. Also, as standard of care, it would be appropriate to do intravenous penicillin, but that often requires that the patient is inpatient. And this was the ideal scenario for the patient to have daily intramuscular injections. So she was able to initiate that that day, and I invited her back even the next day, that afternoon, where she had already received her second injection. And here on this second photo, you can see already an improvement there in the retinitis, and that superior patch is fading pretty quickly. The vitritis is still pretty dramatic, but her symptoms are improving. Her vision's not improving much at this point, but she is encouraged. At this stage of the game, given that she had been on about 48 hours of treatment, and given her ocular findings, I found it appropriate to initiate oral steroids. Now, there's not exactly a standard of care with this, but the literature suggests that 40 milligrams of oral steroids can be helpful in these cases. So I started her on 20 milligrams BID of oral prednisone, and then watching her closely. So you can see from some of these subsequent photos, her vision or her vitritis is improving a little bit. The retinitis is essentially fading away. And by the 22nd of September, where she had completed her course of intramuscular penicillin over about 2 weeks, there was a dramatic improvement in both comfort and in vision. She was about 2,200 at this stage, but she was very encouraged with the course it had taken. In the left eye, as you can see, the findings are almost absent, and her anterior findings in the left eye had almost resolved. But the anterior uveitis in the right was remaining, so we kept her on aggressive topical steroids and still aggressive cycloplegics. So you can see other in subsequent visits. On the 14th of October, we've got an RNFL. We were able to see just a little bit of papillitis left, but her vision had improved even greater and we were able to correct her to 20/40 in the right eye at this stage and 20/30 in the left eye. This last photo that we have here was on the 4th of December, and in which she had maybe just a little bit of vitritis left and maybe the traces of anterior cell left. Now, she was starting to develop a little bit of PSC at this stage in the right eye, though she never had any kind of IOP spike, thankfully, given that we had her on aggressive topical steroids. She was able to keep the IOP down. So this highlights a few important things here. First, on how we treat neurosyphilis, and that when we see these findings in the retina, it is appropriate we treat it as such. But also how we can manage this from beginning to end. We know that syphilis is the great imitator, the great masquerader, and even though panuveitis is very uncommon in the case of syphilis, this has to be on our differential, and especially in the case where there is granulomatous findings. So hopefully you found this interesting, and this patient is going to be continued monitored by us, and she actually has a follow-up with me here pretty soon. But we'll keep you updated possibly on Retina Rocks on how she's doing. So feel free to reach out if you have any further questions about this particular case. Thought we'd just give you a brief summary of how this all worked out and seeing some of these dramatic improvements over serial Optos images. Thanks for your time. I hope this was helpful, guys. Bye-bye.